Hi, everybody. Thanks for joining us. And my name is Marc Fishman. Today, our topic is approaches to substance use in youth. And I'm going to take you on a whirlwind tour of several topics relevant to that idea. Just by way of introduction, I'm a psychiatrist by training. I hope you don't hold that against me. And I do clinical work, administrative work at a medium-sized regional public sector behavioral health substance use disorder treatment outfit in Maryland, and do training, teaching, and clinical research as well. And I'm a faculty member in psychiatry at Hopkins. Let me just show you my disclosures here. I think the one that's most relevant to today's conversation is that I've been a consultant for Alkermes, and they are the pharma company that are the manufacturers of extended release naltrexone, which is a medication for opioid use disorder that I'll mention briefly today. I don't think that biases me, but you guys be the judge. And let me show you a little bit about what we'll be talking about. This is, again, a whirlwind tour. We won't be able to go into in-depth in a lot of these topics, but I wanted to give you an overarching view of some of the general consensus approaches that we use to working with young people. And when we talk about youth, we mean both adolescents and young adults. In Brooklyn, they say youths, right? And it isn't so much a chronological magic red line as much as it's a developmental period in the lifespan, whether you want to say it's 14 to 26, or some people say adolescence doesn't end until the 30s. I don't know, but the idea is it's, again, more of a developmental phase of maturation or immaturation, as the case may be. And we'll talk starting about the scope of the problem. I'll show you some of the epidemiology, who's using what, and some issues surrounding this idea of developmental vulnerability. That is, why is it that young people get into so much trouble? Why is onset and initiation of substance use in the young years such a problem? I'm going to focus on cannabis as one of our topics, not because it's the most dangerous of all the substances by any means, but it is a problem, and it's certainly in the media and on people's minds, and many people have considerable questions about it, especially in this era of so-called medicalization and legalization, and the notion, at least many of my young patients say, well, it's not a drug and everybody's doing it, so what's the fuss? What's the big deal? So we'll talk a little bit about that. We'll spend time on clinical approaches in general, about assessment, intervention, how to communicate both with young people with substance use and their parents, because I think family engagement is so critical as one of the components of the overall approach. And then focus a little bit on opioids, which is incredibly dangerous given the risk of overdose and death in this current opioid epidemic that you all know too much about, but talk a little bit about how we adapt known adult treatments, including medications for OUD, in developmentally specific and informed ways to young people. So, chapter 1, scope of the problem. I want to start by talking about an issue of perspective. Here I am, an old graybeard, and looking to interact with young people. We all talk about the generation gap and the divide in perspectives between the young and the old, and it's important to look at it from both perspectives. For us as oldsters looking to youngsters, and for youngsters, if we can put ourselves for a moment in their shoes, looking at us as oldsters, and think about how to bridge that gap. And many of you will be able to appreciate some of these issues. You may not all be as ancient as me, but you can think a little bit about what you know about young people, whether you've worked clinically with young people, whether you've parented teenagers. Maybe some of you have even been a teenager, if you can remember that far back. But try to think a little bit about this gap in which we as older folks look at the vulnerabilities of young people and think about the trouble they get into and the mischief and their lack of common sense and their impulsiveness and the kind of old geezer view. When I was a boy, we had a better sense of respect, you know, that kind of thing. But also looking at them thinking the way they look at us, and oh, those guys are over the hill, they don't know what they're talking about, they're making such a fuss, they've never experienced these rich, wonderful, energized aspects of youth the way we have. And so I think it's just important to have a look at that perspective. And so look at this quote, which I think nicely encapsulates the thing I'm talking about. This is older adults looking back at younger people and bemoaning how things are so difficult. And it's not like back in the golden age when we were young people, right? We live in a decadent age. Young people no longer respect their parents. They are rude and impatient. They frequent taverns and have no self-respect. Oh, right, that says it all. What a condemnation, right? And when do you think this is from? You know, is it from last week? Is it from the 1830s? And take a look, right? This has been going on a long time. So this generational perspective is important to keep in mind. And our job is to try to do our best to bridge that and to learn how to communicate with young people in a way that they can digest, not just in a way that makes us feel good about what the golden age when things were all perfect was like, ha ha, but more to be able to engage them in a way that we can help them on their journey to maturation and eventually replace us and do the same thing over again, looking back when they're as gray bearded as we are. So let's take a look at some of the epidemiology of who's using what. This is a slice of life, if you will, over the past decade and a half, 2000 to 2015, somewhat dated data, but tells the story and is much the same in the last 5 years, looking at alcohol, tobacco, marijuana, and illicit drugs. And this is lifetime use among 12th graders. So it's who has tried what, who has initiated. Doesn't necessarily talk about problem, doesn't necessarily talk about contemporary or everyday or even recent use, just talks about who's tried what. And there's a number of messages I want you to see. One is that there's an enormous frequency of use, or prevalence, I should say, of use in the population, right? So you could, first you look at alcohol, which is the most prevalent of these substances, and you can assume that people who have used some of the other substances are also subsumed in the alcohol line, because most youngsters have tried, who have tried one of these, have tried more than one of these. And so message number one is that a lot of people have used alcohol. A lot of people have used tobacco, a lot of people have used marijuana, a lot of people, although a lesser number, have used illicit drugs. And point number one is that it's a lot. Point number two, though, is what happens when you ask young people about use and about substances. They tend to say, well, what are you talking to me about that? I'm no different than anybody else. Everybody is using. And so point number two is that, well, maybe they say that everybody's using, but it isn't everybody, is it? If 64% have used alcohol in their lifetime, that means that 36% have never used alcohol in their lifetime. Again, that's a smaller number. It's 2/3, it's the majority that have used, but a full 1/3 have not. And you could subsume those groups together roughly. And the trend is to say that fully 1/3 of 12th graders, which is roughly 18 years old, have never used alcohol, tobacco, cannabis, or illicit drugs in their lifetime. And when you tell young people that, they're somewhat shocked. You tell the parents, they're somewhat shocked. You tell policymakers, they're somewhat shocked. I don't know if you would have guessed at that, but it's important to say, yeah, it's a lot, but it isn't everybody, right? It's a bit of a cohort bias. When you say everybody, I'm talking to a particular youngster, maybe everybody you know, the people you hang out with, as like keeps like company, but it isn't everybody. The other thing is that the numbers of young people who are using are decreasing, right? Look at the numbers of alcohol over a decade and a half, and that number has gone steadily down. That trend has continued in the past 5 years, not shown on the graph. And so 1/3 of 12th graders here have never initiated any of these substances, and that number is increasing. So important point. All right, another important point is to look at the public health success over both this time period, but also going back to the turn of the last century. and 50, 60 years back. The decreases in tobacco use among young people, that's a huge public health success. We've made smoking not cool. I'm not exactly sure how we've done that. I don't know that we can take credit for it, but we'll take it. It's a good thing. Cannabis, roughly flat, right? This doesn't harken back to the days of the mid-70s when we had the peak cannabis use, you know, over the past century in young people, but it's been relatively flat and has been for some time. It's starting to creep up a little as medicalization and legalization takes hold, and that's not reflected here. And then we see other illicit drugs roughly flat. All right, here's binge drinking, just to take a telescope view at alcohol. Now, the alcohol pattern among young people is not daily use, morning drinking, withdrawal symptoms, seizures, DTs, the like. It's binge drinking, in which they tend to start on the weekends and drink large amounts and then stop intermittently. And this is showing us binge drinking among 12th, 10th, and 8th graders. And this is relatively current, as opposed to the view we saw before about lifetime. This is past 2 weeks. And you see that the rates are relatively high, 18% of 12th graders down to 8% of 8th graders, but they again are decreasing. And you should know that binge drinking rates are highest in the youth group as the period in the lifespan where there's the most binge drinking that goes on. Now, here is a range of prevalences of substance use across the lifespan. And I want you to have this developmental view for alcohol, tobacco, binge alcohol, any illicit drugs, and cannabis, right? And this is the percent used in the past month. And the shape of the curve is the same for each of these substances, although the amplitude and the degree, you know, is different. Again, alcohol being the number one. But what do you see here? First of all, you see that the left-hand side of the slide is blown up, right? Showing the second decade of life in a non-linear scale where the rest of the lifespan is condensed on the right side of the slide. And that's not because plenty of people on the right side of the slide are not using substances. Certainly many older adults are using substances, but they started in their youth, right? So this shows us that the left side of the slide is where the action is. It's the ascending limb of the curve. This is a developmental problem of pediatric onset in which initiation happens in the second decade of life, and peak prevalence is at the end of the second decade and beginning of the third decade. So that's a key point. And here's another view about vulnerability. So this is asking adults about their age of onset and looking at the correlation between age of first exposure to these three substances, tobacco, alcohol, and cannabis, correlated with the rates of having one or more of the DSM-4 dependence symptoms as a marker of severity, right? And if you look at these different three substances, you can see that there's between a 2-fold and an 8-fold increase in risk from having onset earlier than age 14 compared to greater than age 17. Just that narrow 3-year developmental window, but it's a very long time in the developmental life of a teenager. So much happens. And if you look across the top, the risk of developing a problem as an adult from initiation of any of these three substances before the age of 14 is roughly 25%. So although it's not 100%, I don't want to exaggerate, 25% risk of coming to harm if initiating before the age of 14. So that's a glimpse of the documentation and the quantification of risk. Here's another view making the point again that the younger they start, the longer they use, the worse the prognosis. This shows us a survival curve of how long from first use to a year of sustained abstinence in the community, right? And the notion of the percent still using at certain years post initiation. And it's stratified into 3 categories, right? In the red, initiation under age 15, in the green, initiation between 15 and 20, and in the blue, initiation over age 21. And you can see, if you read across the middle at the median 50% line, the risk of not achieve, or increasing the time it takes to achieve abstinence in the community increases by 60% with the difference between under 15 initiation and over 21 initiation. So why is that? We know that earlier initiation is problematic. No matter what anybody tells you about, I'm going to teach my kids to drink in my basement, take away their keys, where they'll learn to not drink and drive and drink responsibly. Yeah, if it was a forced choice between drinking and driving and drinking and not driving, sure, but why are there only two doors? What about the notion of abstinence and delaying initiation? So why are they vulnerable? And you can intuit, and we'll talk a little bit about a couple of examples, the notion of adolescent immaturity during what is a very critical developmental period. Adolescents tend to be more impulsive, more excitement seeking, they have more difficulty delaying gratification, and as I'm sure you know, they have more difficulties with immaturities of executive function, which exerts inhibitory control over risky behaviors. This picture here is a time sequence of looking at brain development through the particular process called myelinization, which is a biological process of how the brain matures. And that's just one view of what we know from neuroscience and from psychology about the developing adolescent brain and how that confers through maturity decrease in risk, but how it confers through immaturity before young people are fully baked well into their 20s, how that confers vulnerability. Now, I want to show you one particular example. Many of you may know about the adolescent, about the work of Walter Michel from Stanford University, who did the now famous Stanford Marshmallow Experiment. And I'll show you a brief little cute video, and you may have seen this, and they're all over YouTube, and they're fun to watch. But the fundamental idea is you take 5-year-olds, 6-year-olds, and you put them in a room, and we can watch them on closed circuit TV. But the notion is that you offer them a marshmallow, and you say, if you can delay eating it for 5 minutes, I'd like you to try to delay gratification for 5 minutes. And if you do, I'll give you the reward of 2 marshmallows instead of 1. And then you can see that sense of vulnerability, of the paradigm of temptation and its resistance as an example of executive function, that is the operation of intrinsic inhibitory control and how it exerts an influence on risk behavior. And as you watch these cute little kids, think about the translation then of these same kinds of core concepts of intrinsic inhibitory control and capacity for postponement of gratification, and how they might operate on a teenager given the temptation to intoxicating substances. Well, I'm having a little trouble getting this going. So I'm going to keep moving, and you guys watch that on YouTube, but it's very funny. And the notion is that you can see on their faces how difficult, oh, there we go. Here we go. All right.
Okay, sit in that chair. All right, here's the deal. Marshmallow for you. You can either wait, and I'll give you another one if you wait, or you can eat it now. When I come back, I'll give you another one, so then you'll have 2. But stay in here and stay in the chair till I come back, okay? All right. I'm gonna go do something and then I'll come back.
It smells yummy. It smells really good.
Trying to distract himself. Yeah, they're distracting themselves. You can just see the temptation on their faces and try to intuit their internal conflict. Oh, maybe just a little taste.
All right, so it's up to you. You can have it now or you can wait. Okay? I'll be back. Stay in the chair, okay? Okay.
Pretend. Give it a kiss. They'll never notice, right? Not me, I didn't eat it.
All right, so I'm gonna leave and then I'll come back, okay? So you can either eat it right now or you can wait. Either way, okay? Okay.
Forget you, lady, I'm not waiting.
How'd you do? Did you do good? You did?
Yeah.
You wanted to eat it, didn't you? Yeah. So did I tell you to give you another one? Okay, now you can have both. You need them.
There you go. So just to focus for a second, very cute, but imagine that as a predictor of risk in future behavior. And for our purposes, the thing that it most importantly correlates for discussion of SUD is onset in later life and prevalence of substance use disorders and their progression throughout the lifespan. So it correlates not just with that, though, it correlates remarkably with a whole bunch of functional outcomes. Things like academic performance in elementary school, middle school, and high school graduation rates, college entry rates, college graduation rates, college GPA, adult employment rates, adult salary, adult marital rates, adult subjective ratings of happiness. And I don't want to exaggerate it. It's not one bite of a marshmallow and you're doomed. It isn't 100% correlation by any means. People can change, people can mature, people can reduce risk behaviors. But the notion of being able to avoid temptation, resist temptation, and the paradigm of intrinsic inhibitory control and executive function is apt, and especially in our thinking of vulnerability for young people for substance use disorders. And we know that executive function is immature in younger people. We saw this example of the executive control of a 5-year-old, and it matures over the lifespan, but it's still immature in a teenager and young adult compared to more mature adults. Now, here's another example of a view of executive function. Quick, name the color in the top left-hand corner, and you might say that it's red, or you might say that it's yellow, right? And it's tempting to follow the word, and you can see that this is a 2-signal inhibitory interference task because we have competing sources of we have competing information content from 2 different sources, right? One is the color itself and one is the verbal cue for the color. And in order to do well at this, you have to slow down, think about the rule, not blurt out the first thing that comes to mind, and exert executive inhibitory control, and et cetera. This is called the Stroop test, invented by the evil Dr. Stroop. And again, just another example. But thinking about how younger people are less proficient at a task like this. People who use substances are less proficient at a task like this than people who don't use substances. And young people who use substances, that's a double whammy. And the notion is that life itself is more than 2 signals, it's gazillions of competing signals. And you can easily tell yourself a story about how not being able to sort out all the different input signals of temptation could confer risk. We also think not just about the dimensional variation in the population of vulnerability based on age, but there's also a subset of young people who are particularly vulnerable. And just as we talk about executive function immaturity, it's also important to talk about emotional dysregulation immaturity. And there are some kids who just don't have the same kinds of strengths in emotion regulation as others. And when you talk to parents, sometimes they will be able to tell you, oh yeah, my kids always had some trouble. I've had several kids, and this kid is different than the other kids. This was the kid that was tantrumy. This is the kid that couldn't sleep well. This is the kid that had poor frustration tolerance. This was the kid that had peer interaction troubles. This was the kid that had playground aggressiveness. And so all of these vulnerabilities can cohere to form a matrix of risk. And it's those kids that tend to be at risk later on. These things breed true. The same kid that was a tantrumer at 6 months is more likely, again, it's not 100% correlation, it isn't fixed fate, but is more likely to be the kid that later develops substance use disorder and progresses through that vulnerability. So this teenager looking at you should not be a surprise. Mom, you've ruined my life. Hey, listen, if I've only ruined your life once in the past hour, it's a good day, right? We shouldn't be surprised. All right, so there's the chapter on vulnerability and scope of the problem. I want to shift now to the chapter on cannabis. This is just some graphics looking at some of the features of modern cannabis use. One is the cultural icon that conveys the glorification of cannabis. That's Snoop Dogg, for those of you who don't know. We also see young people smoking large quantities of cannabis in big blunts. We see edibles, we see syrups. All of you know, right, that the cannabis of today is a much more potent drug, much more potent deliverer of the active ingredient THC than the cannabis of decades ago. That's because the same hybridizing botanical geniuses, you know, who through crossbreeding have brought you the miracle rices and other crops to increase protein, have done the same thing to increase THC content, and we've increased THC content, you know, by 5 to 15-fold in some instances. And so it's not your grandfather's reefer from the 1920s. This is a much different substance, and many parents don't appreciate that. Now, why do we care? Is it because cannabis will kill you in an overdose the way opioids do? No, of course not. Nobody's ever died of a cannabis overdose. Is it because it's immoral and because nobody should ever have access to cannabis? It's the devil's weed? No, of course not. It's instead a health risk, right? And we should think about it much the same way, in my view, that we think about alcohol. Alcohol isn't bad for everybody. Lots of people use alcohol responsibly, drink beer at a football game or have a glass of wine with dinner. The issue is that there are some people that are more vulnerable to lose control and develop use disorders and addiction. And it's the same for cannabis. It's not the majority, but it is a substantial minority. And there are particular vulnerable populations. Today we're talking about young people, and they are such a vulnerable population. It's also people with psychiatric illnesses and other substance use disorders, but we're going to focus on youth. And youth are at considerable risk. Again, it's not the majority of youth that develop an addiction to cannabis, but a much larger number of youth who are exposed to cannabis get into trouble. We're also concerned with the acute consequences of intoxication, such as motor vehicle crashes and traumatic injuries. We're also concerned with the psychiatric consequences of use. We don't have time to look at this data, but there's data about cannabis use as worsening depression and anxiety, cannabis use as worsening the risk of psychosis, and cannabis use as worsening cognitive impairment in an enduring way that may or may not be reversible. Most important, of course, is this issue of use leading to progression. And experimental initiation, which might be normative, right? Kids get into stuff, but a sizable subgroup of them will progress to cannabis use disorders and then on to other substance use disorders. And that's why we care, not from a moral perspective, but from a health perspective. So a couple of features to know about that. One is the reciprocal relationship between perceived risk of harm and use. As perception of risk goes up, use goes down. As perception of risk goes down, as it is in the contemporary era, when people aren't as worried about it, cannabis isn't even a drug, it's a medicine, it's legal, it's no big deal, then use will go up. There is the cultural issue. We already talked about Snoop, but here are other cultural icons of intoxication. All you have to do is turn on the TV, turn on Netflix, listen to modern pop radio. And for young people, it is the water they swim in, and intoxication is associated with the glamorous life, with luxury, with being cool. And that's a very difficult cultural trend for us to counter message against, but an important counter messaging nonetheless. And for those who say, well, it is normative that young people will get into stuff and do risk behaviors and experiment with this, that, and the other, whether it's with alcohol, whether it's with unprotected sex, whether it's riding the bicycle without a helmet and driving without a seatbelt. Yes, young people get into stuff. And so you can argue that little bits of experimental use are normative, but I don't think most people would argue that daily use is non-problematic and to be ignored. And I just want you to see this picture of daily use, right? And we're now in an era, and remember I said that there was a higher peak back in the 70s. We fortunately haven't reached back to that higher peak, but we are increasing. And 6% of 12th graders are daily users every dang day. I guess the good news is if you look at the 8th graders, it's only 1.2%. But the bad news is that 1.2% of 8th graders are daily cannabis users. And here's some data about the risk that confers. This is longitudinal data from Australia. And we see that daily use of cannabis under the age of 17 is associated with some considerable risks. An 18-fold risk of persistence of cannabis addiction into adulthood, a 3-fold increased risk of high school dropout, an 8-fold increased risk of use of other non-cannabis drugs, and a 7-fold increased risk of suicide attempts. Again, I don't want to exaggerate it. This isn't 100%. This isn't one puff and you try to kill your grandmother or commit suicide, but these are, to me, in any case, scary numbers. So what are we going to do about that? And I think it's a problem all of us have to wrestle with. I want to take it out of the realm of a moral conversation. We've been too easily cast in the role of puritanical prohibitionists. That's not the point. It's not that nobody should ever touch cannabis. It's not that everybody who touches cannabis gets in trouble. On the contrary, like alcohol. But we are concerned with the progression to problem use. And broader use does lead to broader problem use for a subset, and that's a big problem for young people. And you have to think about what does that mean as we increasingly medicalize it, and think by analogy to what happened with the US prescription opioid problem as we over-medicalized access to opioid analgesics and see where that got us. And the same by analogy to the recreational commercialization, like alcohol, when it's on billboards and the big boys and girls in Wall Street get a hold of it, think what that means, right? So this kind of messaging is not helpful. This is the historical, non-credible, the historical exaggeration, the devil's weed, the smoke of hell, one puff, and you're doomed to hell. That doesn't help. How can we get to some kind of credible messaging that will help young people? And I just want you to see this message. This is from Amsterdam. But listen, on a hot summer day, who wouldn't want cannabis ice cream? And this is what we're going to have to message against. Again, when it's on every billboard, much like it is for alcohol. And I want you all to think about how to phrase that, how to message it, how to have conversations with young people and their parents to counter message. So with that, let's use that as a transition to chapter 3 and talk about clinical approaches. So the first thing, and you guys all know about stages of change, is you don't want to set yourself up, as I know you know, that young people presenting for treatment or presenting for screening or presenting for assessment, or their parents presenting for, hey, I've got a kid with a problem, you certainly wouldn't expect that they're going to come in action phase, ready to do everything you say, with the notion that abstinence is the course they're seeking, that they recognize that the source of their impairment is their cannabis use. No, of course not. They're going to come in pre-contemplative. And in fact, most of my patients are in pre-contemplation. So we're going to be working on motivational enhancement. And how are you going to do that? And you guys, I'm sure, are all very experienced in motivational interviewing and motivational enhancement therapy. I just want to give you some language that I think is helpful, a voice and a way of framing these kinds of conversations with the young people that you see talking. We'll use as an example cannabis, but it could be any substance that you're talking about. But I mentioned cannabis in particular because the issue is that their assumption, as you know, their assumption is that everybody's doing it. It's not a big deal. Why are you bothering me? And it's hardly even a drug anymore. So shut up, Dr. Fishman. So one of the things to start with is that they'll tell you it's not a problem. I don't do that much. It hasn't affected me. I'm not impaired. Okay, well, let's examine that. Maybe it's not a problem for you, but now let's do an end around approach. You must know some other kids who use too much, who have been in trouble. Let's talk about examples of the people you know who have crossed the line, who have been in trouble. What's different about them? Why are they in trouble? Why is it too much? And you can see that the thing we're doing there is we're at least getting the conversation onto a frame where we're on the same page. We're having a conversation that there is such a thing as too much. There is such a thing as being in trouble as a direct result of cannabis use. Maybe it's not you, fine, but there's somebody, and we can talk about, well, what's that line and what's the difference and what do you think constitutes impairment and what's the relationship? And you might say, well, why is it that myself as the clinician, or your parents who may have fussed at you, why do you think that we might think it's a problem? I'm not saying you agree with us. I'm not saying that you think we're right. That's fine. You can disagree with us, but can you articulate why you think we might think that? And you can see what we're doing. We're getting the adolescent to try to think outside himself, adopt somebody else's perspective. That's a very important developmental goal of the maturation of this time of life. And you might ask, well, so what are the pros and cons for you about this use? Well, listen, if I think it's so much cons, why would I even ask them about the pros? Well, people use intoxicants because it feels good. They wouldn't do it if there weren't pros. So having that conversation and acknowledging it earns you credibility points. And you start with the pros and you say, what do you like about it? And what don't you like about it? Or what are the potential pitfalls? Well, there's nothing wrong. I don't have any cons. It's all pros. Okay, that's fine. But what could those cons be if it progressed? What are the risk points or the balance points around if it got worse, like the kid you told me about, your friend Johnny? What would the evidence be, in your view, that it had become a problem? You told me that you only smoke after school, after your homework's done. So are you saying that if you smoked before you finished your homework, that would be evidence that it's gone too far? Or would you say that if you smoke before school in the morning, that would be the line that it's too much? You say you only smoke on the weekends. If you started smoking during the week, would that be a problem? You say you only smoke once a day. If it got to 2 times a day, is that the line? You say you only smoke with your friends when you're chilling. Well, what if you were smoking alone? Would that be a sign? And you see where I'm going is that you want to establish a beachhead to have a longitudinal conversation, because it's a marathon, not a sprint. You're not going to get it all done today. There's not going to be any big epiphany, aha. It's going to be a gradual engagement over this longitudinal view, and asking them to consider in the pageant of their own lives, not some textbook, not some preaching from me as an old person, but thinking about, in speculation, what might be the bridge too far. Well, you say you could stop anytime. Have you? Is it easy? Is it not easy? How do you know? Would you be willing to try it out? After all, it's not going anywhere. You can always come back to it, but would you be willing to try to cut down or to stop and see, is it hard? Is it not? Is life better? Is it not better? Is it worse? Let's explore together. And we're establishing an alliance. We're establishing a collaboration of a common endeavor. Listen, other people are fussing at you. You may agree with them, you may not, but take things into your own hands and explore it rather than just dismissing them. Let's try to understand them. And if you think that they're wrong-headed, let's develop the evidence together that they're wrong, or learn together. And most importantly, an acknowledgement of their honesty and integrity. I'm glad you're telling me the truth. I'm glad you're just nodding. You're not just nodding and saying, okay, I'll stop. It's bad for me. I'll never use again. Because you know that's not true. That they could say that, but that wouldn't be true. You'd rather that they're honest, and you want to praise them for it. Thank you for your honesty. Thanks for being open with me. We may not see eye to eye on this. In fact, we can explicitly agree to disagree. I use that phrase a lot. But this is the beginning of an ongoing conversation. Would you come back and continue to talk to me about it? Could we view how this has gone? And then when they do come back, you can say, well, here, it says in my notes that you said that if you smoke before homework, that would be a problem. Well, I thought that, but I've changed my mind, and now I realize I'm doing my homework. Well, okay, but let's see how this evolves over time. And with the progression of people continuously or progressively crossing lines that they said they wouldn't cross, maybe that's more persuasive. Well, will you come back and see me? Well, will you go and see a specialist? Will you get another opinion? Again, you don't have to agree with them, but let's ask the experts, and et cetera. Again, getting people involved in the conversation is critical. 95% is just showing up. And that's why I always say that pizza ought to be a Medicaid reimbursable expense, right? Because anything you can do to get kids involved is a help towards having the conversation. I think it's important to think about the ground rules for communication. So how are we going to involve their parents? And you might say, well, no kid wants you to talk to the parents about it, and that's a betrayal of trust and confidentiality. And I want to say, on the contrary, I think that it's important to finesse this issue and think about how we can involve parents, because parents do have much more juice than they know. And so the balance between the rules of communication and confidentiality and getting to yes about an agreement to talk to parents can be very helpful. So this is your private treatment, and I will not go blabbing everything, but I am concerned about you, and your parents care about you. And besides, you're already in trouble with them, say, and so maybe I can help run interference and protect you from their nagging. And maybe they don't really understand. And by the way, you're going to get busted anyway. The truth always comes out. You can only keep alive for so long. So wouldn't you get more parent points if you brought it to them honestly and could figure out a way to get credit for that honesty? And let me help you and model that for you and that kind of thing. If you can bring the parents in the room and show them that you can set limits on the parents and get them to back down a little bit and not be so punitive, that's gold in terms of credibility. Now, you make individual decisions as a clinician when there is an imminent need to disclose. Most of the time, though, it's not an emergency. You don't have to talk to the parents and tell them the nitty-gritty details today. We've got time for that. I mean, unless you think somebody's at risk of an injection heroin overdose, that may be a different story. But for cannabis, you've got time. It's not an emergency. You can set limits on the parents. You can say to the parents, listen, I want to include you, but I'm only going to tell you stuff on a need-to-know basis. And you got to trust me on that. And by developing that kind of relationship with both parties, listen, I've done this before. I'll filter information in the most expedient way. You can fire me anytime, but in the meantime, let me help you guys agree to this communication. And then hopefully setting a model for them doing it on their own, even when you're not in the room. I think there's sometimes a question of what do you do about parental use? How do you deal with that? There might be multi-generational use. There might just be normative use, even non-problem use. You don't know. But even when you suspect problem use, how do you bring that up? That's very tricky. The parents might say, well, I didn't come to talk about me. That's none of your business. How dare you insinuate that I have a problem? I'm here for my kid. And so I take a universal precautions approach to that. I say, listen, I don't know what happens in your house, and not applies to you, but some families, there may be social or recreational or normative use of alcohol or cannabis or whatever. But you know, kids are mimics, and they do what you do more than they do what you say. So I know I'm asking a lot, and maybe this is unreasonable, but one of the things we do when we talk to families of a kid where there's a problem and we're trying to get the kid to stop using is we declare, at least temporarily, a substance-free household. And I know that's an imposition, and it's not forever, and I don't mean anything by it. But if there is alcohol in the house, if there is cannabis in the house, it will help the kid if just for now, right, you can stop that. And some families will take to that approach and it will work, and other families will still be offended and say, how dare you? But it's one way of trying to approach that. And then the follow-up monitoring. Remember, I talked about longitudinal approaches. How did you do? Is it better? Is it worse? How's it been going since our last visit? Have you thought about what we talked about? How much have you been using? Did you try to stop? Did you try to cut down? Have you crossed a line that you said you wouldn't cross? I have in my notes, as we said before. And wow, it seems like you're in trouble. How do we get help from your family before you really get in trouble, either with your family, with your school, with the law, et cetera, et cetera? And we don't really have time to talk about it, but it is important to develop some ability to incorporate urine drug testing. If those of you in the audience are primary care, physicians may think, wow, that escalates it. They'll think I'm being punitive, and I think you should try to learn to bring it into the routine as you would with any other lab test. It medicalizes it or clinicalizes it. It's just one tool we use. We do this for everybody. It's not a big deal. I'm not accusing you of lying. It's just a monitoring tool that we do and try to detoxify it. But anyway, it just depends partly on the workflow and how easy it is to do in your clinical setting. All right, and I know we are getting towards the end of our time, but I want to get to chapter 4 and talk some about opioids, because it is such an important topic, because they are so dangerous, because we still remain in the midst of an opioid epidemic, and youth are definitely vulnerable to overdose and overdose death and all the other catastrophic consequences. So I want to show you that young adults are disproportionately affected by this opioid problem. This shows us non-medical use of prescription opioids, and in the top line with the plus signs and squares, you can see that 18 to 25-year-olds on a per capita basis have the highest rates of past month non-medical use of prescription opioids across the lifespan. So they are disproportionately affected, and the same thing is true of heroin. You can see the scale is smaller. There are fewer heroin users than prescription opioid users, but again, young adults 18 to 25, more per capita use of heroin than at any other period in the lifespan, and disproportionate impact. And then not only that, as we've discussed, since the vulnerable time of initiation in the second decade into the beginning of the third decade of life, it's an opportunity before this problem has progressed for too many years, before it's had a chance to crystallize to its most malignant form. We have the notion that intervention here is likely to be most effective. As with all chronic remitting relapsing illness, early intervention makes a difference. Now, how do they get to OUD? How do they get to opioids? There is this media myth, right, of the star football player who has an ankle injury and meets an evil orthopedist and then plummets from star athlete, a star academic performer, all A's, golden boy, golden girl, to next day injecting heroin under a bridge. And while I'm sure that that has happened, that is hardly the common trajectory, right? The vast majority of youth who initiate opioids have previously had problems with other non-opioid substances first. Most youth who get prescribed medical opioid pain medicines for medical uses do not divert, do not use non-medically, only use as prescribed and then stop using when the prescription ends. There are a subgroup who don't have it go well, but mostly initiation of opioids by young people is with non-medical use. So having said that, hearkening back to the clinical approaches and interventions for cannabis and alcohol that we previously talked about, I want to make the point that intervening prior to initiation of opioids, intervening by identifying, assessing, and treating youth SUD, non-opioid youth SUD, is in itself a key, maybe the most important, a key prevention intervention strategy to prevent youth OUD. Now, what about treatment? So now young people who have advanced to opioid addiction, what's our best approach? And obviously, it is a comprehensive, multi-component approach that includes all the different tools at our disposal. But I want to emphasize for a minute the use of medications for opioid use disorder, or MOUD, or to use other terminology, MAT, medication-assisted treatment, and make the point that we all know or should know that at least in adults, the 3 FDA-approved medications for OUD, that is methadone, buprenorphine, and naltrexone, are the standard of care, right? We have very effective medications that we use as first-line treatment in older adults for opioid addiction. Well, what about young people? Well, as it turns out, those same medicines, and we emphasize buprenorphine and naltrexone more than methadone because there aren't really good developmentally informed models of methadone delivery, but at least for buprenorphine and naltrexone, there is considerable and emerging evidence. There's not as much science as for older adults, but there's plenty of it, and the data grows stronger every day, and broad clinical consensus that the use of these medicines should be first line for adolescents and young adults. Buprenorphine is effective. Even though the outcomes are not as good for older adults, they are still well worth having. Longer duration of treatment is better. There's no evidence for a arbitrarily set time limitation that we should quickly get patients off, even if they are young. Extended release naltrexone is also very promising, although there is less research about it than there is about buprenorphine. Now, we always worry about the pediatric application of medications as to safety problems and the developing mind, the developing brain, the developing endocrine system. So we worry, should we be giving these medicines to young people? And the good news is that so far, there is no signal, I repeat, no suggestion that there are additional safety problems conferred based on age. Now, every medicine can have potential side effects. These medicines are no different, but there's no reason for us to think that younger people have higher rates of difficulty or specially age-related side effects. So that's good news. There's also no evidence or no rationale to suspect that we should wait to initiate those medicines until young patients have failed other non-medication treatments, right? These are first-line treatments. Remember, in opioid use disorder, failing a treatment can be a fatal event, right, with an opioid overdose. So waiting for second line, third line, fourth try, been through detox 6 times without medications, okay, now let's give them medication. Not okay. Medicine should be first line, and we should think about any opportunity to treat young people with opioid addiction. One of the tools should be to initiate MOUD. So that here are the recommendations here, that youth SUD providers should prioritize OUD treatment and include the use of MOUD. So people who are already engaging young people and their families, who already have the tricks and tools to engage youth, should add MOUD and specialty programming for OUD to their repertoire. Medical providers who are already treating youth, whether that's pediatricians or family practice, should learn to identify OUD in their patient populations and incorporate MOUD, buprenorphine is the easiest, into their practices. Some pediatricians tell me that, oh gosh, if I put up a sign that says we're offering buprenorphine, there's going to be a line around the block, and every kid within an 80-mile radius is going to want to come to me and will suddenly become a buprenorphine specialty provider. Well, it turns out that doesn't happen. I'm not talking about reaching out to everybody's buprenorphine cases. I'm only saying that you've already got these young people in your practices. You don't know it. You're not asking about them and offering the treatment. So the same way that you would provide them with any treatment for any other chronic remitting relapsing illness and other risk behaviors, the way you ask about their sexual risk behaviors and their seatbelt risk behaviors and their smoking risk behaviors, you could target OUD and it wouldn't be that difficult. We should think about upstream touch points. What do I mean by that? Well, by the time young people get to specialty SUD, OUD care, like my clinical setting, it's good, we want them to do that, but they're already pretty far down the line. What about upstream in the emergency department at the point of overdose or at the point of a medical consequence such as a soft tissue infection? What about hospitalization? What about psychiatric hospitalization? What about the juvenile justice system? So all of those are potential points where we could do a better job of identifying youth OUD, and not just identifying it, but initiating MOUD, buprenorphine or others, and then linking them to specialty care. I want to just make a quick plug for work that we've been doing in Baltimore at our center. This will not necessarily generalize or scale to everybody. It's a bit of a heavy lift, but thinking about a developmentally informed, high-touch, intensive treatment for deep-end youngsters with OUD. We're doing this multi-component treatment intervention we call YOURS, the Youth Opioid Recovery Support System, and it's borrowed from the playbook of assertive community treatment. You may know of that as a treatment for chronic and persistent severe mental illness like schizophrenia, where people use a multidisciplinary treatment approach where they involve families and other natural supports, and they go out into the community to reach patients where they are, including the home delivery of long-acting injectable medications for schizophrenia, those being long-acting injectable antipsychotics. But for youth with OUD, it's long-acting injectable naltrexone, brand name Vivitrol, or long-acting injectable buprenorphine, brand name Sublocade. And we've now published a couple of studies on this and started to test it. And the good news is that we get better results than in treatment as usual. The bad news is not everybody responds well, and I don't yet know how to pay for it outside of special research resources, how to scale it under Medicaid pennies, but of interest to think that we could develop, and this is just one example, we could develop innovative youth-friendly engagement tools that might be better able to welcome and capture young people. All right, so I just want to conclude with a couple of take-home points. We've talked about vulnerability and that young people have specific developmental vulnerabilities that makes them more likely to get into trouble with substances, all the way from alcohol to cannabis, up to heroin and fentanyl, and that all of those substances with progressive use are associated with severe psychosocial impairment, and in the worst case in opioids, with vulnerability for overdose death. If we can develop developmentally informed treatment for youth that addresses their special needs, we can do better than if we just treat them as short adults and give them the same old, same old. We need to be very clear in our prevention messaging, which is to say this isn't a moral problem. We are not condemning or judging. We are only saying it is bad for your health, and young people should not initiate intoxicating substances. Am I so naive to think that just because I say it, they will do it? Of course not. It's a balance. But because we are healthcare providers and or parents, they carry our voices in their heads. And although they may not agree with us every time, and although they will certainly not do what we say every time, it is important that we are clear in the message. In thinking about OUD, I emphasized the role of relapse prevention medications, or MAT or MOUD. But in general, the good news is that youth SUD treatment is effective and recovery happens. We are at a crossroads. We need to think about SUD writ large as a developmental disorder of pediatric onset. We have to broaden our scope. We have to reach in and take our existing and emerging toolbox and overcome the problem of what is an alarmingly low level of adoption and utilization despite the evidence. We have to press on with therapeutic optimism. One of the things, even if we don't have the curative treatments or the most effective treatments that we hope we will develop but may not have developed yet, by talking to young people and their families with optimism and saying that we have your back, that we will advocate for you, that we will try to get you through this, that's one of our best tools. And so I appreciate all of you being interested in this topic and doing the work that you're doing. And I'll just conclude now with this silly picture of hypothetical miracle cures, right? We wish we could give them all brain transplants and catapult them instantly into maturation. And although that's a joke on the one hand, on the other hand, there is some reality to it. If you keep them alive enough, right, maturity, at least for a subset, does happen. If you keep them alive long enough, they will grow up, and you can help support them in their emerging adulthood and the transition as expected through maturation and discovering their strengths and who they are, that you can get them to the other side. So that's our hope and the optimistic message that I'll stop with. Thanks so much for your attention. I hope that was helpful, and have a good rest of your conference.